Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric OKelly. This week, we are again with Dr. Ella Corrick and Dr. Tom Mallinson. Ella is head of our doctoral program, and Tom is head of our bachelor's program. And both of ye, welcome back to the podcast.
Thanks very much.
Hello, good to be back.
Next week, the college travels to Raleigh, North Carolina for the annual Special Operations Medical Association Conference. We're offering 3 workshops. Tom and Ella are running the Wilderness Paramedic Workshop. John Clark is running the Tactical Medicine Review, and I'm running Improvised Medicine Workshop. We'll be a bit busy, and we again have our exhibitors table. But for this talk, I wanted to focus on the Wilderness Paramedic. So, Tom and Ella, both of ye, this is the 3rd SOMA Conference that you've attended. And I remember your hesitation 3 years ago on why a soft conference would have room for two civilian doctors with zero military experience. And now that you've been here twice, and now you're a big part of presenting at the conference, what are your thoughts?
Well, I think one of our reservations, as you say, was neither of us are military in any way. So we were having trouble conceptualizing whether anyone would be interested in what we had to say, and equally whether anything they were talking about had relevance to our practice. But then I think we very rapidly realized that SOMA is extremely welcoming, for one. So we just felt very welcomed. It was a very friendly environment. And also, so many of the challenges were exactly the same. Clearly, there's the non-permissive environment element, which is very different for us. In general, we are not getting shot at, but we share a lot of the same challenges and problems about rurality, distance to hospitals, limited equipment, limited medications. You know, that's all very similar and the same problems that we face in maybe our mountain rescue practice or just our rural pre-hospital care practice. So I think rapidly for me, I saw that common ground in what we were all talking about.
Yeah, I was feeling the same. And I think with Quorum's focus is on austere medicine, and there's so much austere medicine at SOMA. And so the workshops that I've attended and the talks I've attended in the 2 years that I've been before, I had a lot to learn from the other people there, and hopefully also had some experiences that I could share with them that they could learn from. And even if people were working in really different settings, I remember talking to people who were kind of law enforcement and in a very tactical role, but they had the same challenge we have in remote and rural practice of delivering rapid analgesia and having team members who aren't necessarily highly medically trained, but needing to deliver advanced analgesia. And so we were talking about different delivery models for fentanyl and stuff like that. So there's all this shared learning and parallel practice, which I've really enjoyed being there.
I think also for me, and I think Ella, we've talked about this before, is the concept of prolonged field care is shared by many different agencies and practitioners. And as mixed hospitalists and pre-hospitalists, we already have a bit of an inside track in prolonged field care because we've both cared for pretty sick people on a rural island where retrieval of that patient is going to take time. So again, it's a very different environment in which you're providing prolonged field care, but we've both done that. And I think that was a really nice foundation of common ground, of we both understand that challenge of looking after a critically unwell patient for a lot longer than you'd like to when you'd really rather they were sent off to a tertiary referral centre. So I think that was really nice common ground that we found with a lot of people at SOMA.
So you find that you do indeed have contributions that you can give to the SOMA community?
Well, I hope so. I mean, everyone there is very polite, so they might just be playing along. But we've certainly had some very interesting discussions where we've bounced ideas backwards and forwards between, high-level military operatives coming to ask us about how we overcome problems in our civilian practice. So I think we've definitely had some really valuable discussions.
And have you found other attendees who are civilian only that are similar background to yourselves?
Yeah, I mean, there's certainly last year we definitely bumped into a few search and rescue team members, some mountain rescue guys. There's definitely quite a large civilian presence at SOMA on that side of austere medicine, far from help medicine, which was surprising. I thought it would be 100% military, but there's definitely that continuum of military, law enforcement, and then civilian, but working in a similar austere setting. That was my take home from that.
And I find it really fun talking to people who do practice in similar roles to us, but in equally a completely different country and different types of terrain. I was speaking to some of the search and rescue guys who are based in Colorado, and we've got all these shared challenges, like, maintaining training, maintaining skills that you only use occasionally, travel distances. And then we have some really different challenges. Their mountains are far, far bigger than ours and more mountainous, but the sort of area that my team covers is really big, and our hospitals are very few and far between. So I really enjoy talking to people, and every team's got different solutions to their problems, and some of them are problems that we don't have, and so it's just fascinating hearing how they overcome them. But some of them are problems that we all have, deciding what kind of litter or stretcher to have for your team, deciding how to divide technical skills within your team. All of that is stuff that you can talk about and learn from.
This year, you're going to be presenting the Wilderness Paramedic Review Program. So for the listener who doesn't know what the WPC is, can you give us an overview?
The WPC is one of the IBSC qualifications that focuses on, as the name suggests, wilderness practice. And so it's aimed at people who are practicing in remote settings. So that might be people who are medics for search and rescue teams, or it might be people who are actually going out on expeditions who are going to need to be providing not only first aid, but beyond first aid because they're so remote. And also people who are in really remote or austere environments, maybe running a small clinic or providing some interim care for patients. And it covers a really broad curriculum. A lot of it is focused on environmental medicine, so things around hypothermia or heat illness, kind of challenging fauna and flora you might come across. But then there's also things that are more focused on practices that might apply in any of those environments, so critical care in remote settings, prolonged field care. And then there's a separate wing again to the curriculum which looks at technical rescue and search and rescue skills. So it covers this really wide range and allows people to demonstrate that they've achieved a reasonably advanced level in all of those skills in a wilderness setting.
And I think for me, it was, so Ella and I both sat the exam to see what it was like and as a bit of a test. And I think for me, going into it, it was difficult to quite conceptualize what the exam was going to be. Certainly in the UK, we don't really use the terminology wilderness medicine as much as they do in North America. So we probably talk more about expedition medicine as a concept. So when we went into that and when we were thinking about how to study and prep for that, for the WPC exam, we certainly took a very broad approach to that study and that exam prep. I've still got a pile next to me of kind of 15 to 20 books that we tracked down to cover all of the nuanced areas of the curriculum because it's such a broad curriculum. And then, so we did a fair amount of reading across all of those books. But then when we came to sitting the exam, I think we were quite pleasantly surprised that it was a very broad curriculum, and that broad curriculum is tested, but they're very sensible real world questions. I think for me, I wasn't sure how they were going to manage to ask those questions about wilderness medicine because as a terminology, it's not the terminology I would use. But then having sat the exam, you come away thinking those were actually fairly sensible questions for someone who might be in mountain rescue or search and rescue or any far from help medical provision role, really.
Yeah, I agree. It felt like a very fair exam. When you look at the curriculum, it's so broad, it was difficult to know how to prepare. And I think depending on a person's background, there's going to be different areas that they would probably need to study to get up to the level, and it's going to be different for every person. But I don't think there's that many people who, unless they're day in, day out doing wilderness practice, who would be able to just jump in. Because even if you're, let's say, an experienced mountain guide, then I think some of the austere critical care stuff might trip you up if you didn't prepare. And on the other side of things, if you're a practiced urban medic, then some of the environmental medicine or the rope rescue questions might trip you up. So there's probably different sections that will be different for people depending on what their day-to-day practice is.
And I think for us, or certainly for me, it really... So Ella and I are both mountain rescue doctors, but we were very aware that in this certification exam, there was quite a large section on technical rescue, including rope rescue. And for me, it certainly brought into focus that I fairly heavily rely on the experts in my team who are the rope rescue experts. So I'm fairly competent, I think, on a rope system. Touch wood, I haven't fallen off yet. But it really highlighted that, that's an area where I can really focus my studies, and where we made sure we had some good up-to-date texts to refer to and to try to get on top of the core concepts for rope rescue, because I think there is a difference between being a day-to-day practitioner who can work on a rope system and being someone who could sit this exam and know some of the more technical details of setting up and utilizing rope rescue systems. So as Ella said, I think depending on the individual, you probably need to focus on different areas of that curriculum depending on your strengths and weaknesses.
It's interesting. It gives a skill set that the mountain team... So in the Green Berets, we have 6 teams in a company, and each of the 6 teams has a specialty. I was on a Merops, so it's all about water. But there is a mountain team that is all about climbing, and they do this. This is their curriculum. And whenever someone gets to for us is 163, the 3 team was mountain, and they had to learn how to rock climb. They had to learn how to do these rope rescues. They had to learn how to get a mortar base plate up a cliff, and they needed all of these skills. And it sounds like WPCs is something that would be very beneficial for a mountain team.
Yeah, it's got that breadth, and it doesn't expect you to be leading that technical rope team. I think like Tom said, I think it's a fair exam. You know, you're not expected to design a new rope rescue system, but what you are expected, and I think that this is the right expectation for someone who's going to be involved in any technical rescue, is that you understand which systems should be in place before it's safe for you, your team, or your patient, and that you understand why that system might be used. And maybe you know some of the really high risk mistakes that can be made, so that you can be part of your team's safety net in spotting those mistakes before they happen. And a lot of it is focused, maybe not so much around the technical skills, but a lot of the questions are around the decision making of what's going to be the best way to get this patient out, or should we attempt to initiate a rescue at this stage, or should we be doing something different? And even just decisions about when do patients need to be evacuated, that's a really large part of the question bank. So it doesn't only ask you for specific technical knowledge, but actually asks you about using that knowledge to make decisions, which I think is a much more interesting bit of skill to test, really, than have you memorized the curriculum.
And I think equally on that topic, I think those questions might be the ones that trip people up if you aren't used to working in a remote, austere setting, because there were those smattering of questions that were very scenario-based and were very sort of what is the sensible plan to do in this situation? And I think if you have a good, solid background working in mountain rescue with other practitioners and experts that have decades of experience in that environment, those questions become easier. But I think if you're more naive to operating in a wilderness setting, those questions might really trip you up.
I remember after both separately sitting the exam a couple of weeks apart, and financial disclaimer, IBSC generously gave us a discount for that. But after the exam, we were kind of talking through the curriculum and how it fit to the blueprint they publish. And I remember saying so much of it felt like almost making a common sense decision, making that judgment call of of whether or not to evacuate, making a judgment call about a search strategy or about an evacuation plan. And we were discussing how do you teach that to someone, because I think that's a really difficult thing to teach. To some extent, it's something most people end up acquiring through experience of seeing other people making those decisions and hearing them discussed, but more difficult, I think, to actually teach someone.
I sat on the curriculum committee for the WPC, and there were people from all over the world, and I was trying very hard to get an austere side of the WPC and not have it focus only on mountain rescue. Have you seen that in the exam? Is there austere medicine, prolonged field care, or is there remote medicine concepts within the curriculum?
Yeah, definitely. I think that there is still probably a kind of tendency towards mountain rescue and mountain medicine, but there are PFC, prolonged field care, is a big part of the blueprint. And I think because I haven't studied prolonged field care from a kind of military perspective, I have come across it more through my medical practice. I didn't always recognize those questions as being PFC or being austere, but there are questions about, you're caring for a patient and their nursing needs and the kind of how do you manage their skin integrity when you're alone caring for this patient. So there's definitely elements of that, and there's elements also of improvised medicine, which will appeal to you, Aebhric, all based in the setting of you're in this austere environment and maybe you don't have all the equipment that you would like to have. Which of these is the best options to use what you do have available to you?
And I think that issue around prolonged field care, because we've talked about that after we sat the exam, I think I recognised more of the questions as being PFC questions than you did. But I think that's because prolonged field care is just providing good patient care, and it's providing good personal care or historically nursing care. And I think if you were sitting this exam and you've had experience of caring for patients for longer periods of time, those elements and those questions will seem more natural and more obvious to you. Because, so certainly when I worked on, when I had a critical care job, every day you would think about pressure areas, hydration, nutritional status. And I think then those build into your approach to patient care. So I guess perhaps if you were a more urban EMS provider and you were closer to hospital and you never had to look after a patient for 6 hours and think, oh, when did they last have something to eat or drink? I think those questions might trip you up, and then you would really benefit from doing more reading around prolonged field care. But I think it really highlighted that prolonged field care is just good patient care.
The two of you have vast experience in prolonged field care. You didn't call it PFC, did you? You just called it providing care.
Yeah, and that's definitely true. And I would love to take loads of credit for being amazing at that. But we are certainly very lucky that we often have excellent nursing staff supporting us wherever we're working. So many of our roles, we share a lot of that work with the nursing staff. And I've certainly learnt lots from nurses pointing out where we need to provide better prolonged field care, when we need to provide better personal care. So I guess that's another benefit of, depending on what your working history is, or perhaps if you are a nurse, clearly this area is going to be your bread and butter. But again, if your career path hasn't taken you into the opportunities to learn from those experienced nurses, it's going to be much more challenging. So yes, Ella and I definitely have undertaken prolonged care for patients, but hopefully we have got better at that thanks to working alongside some hugely experienced nursing colleagues who have nudged us in the right direction of what we should be doing.
Well, I guess if I had to do this over again, I should have started out as a nurse first and then a paramedic, because I think that would have made me a much better paramedic.
Yeah, it's interesting, isn't it? Certainly in the UK, there's a move towards having integrated master's degrees so that you can you can read for a single master's degree, and then you come out the end of it as a nurse and a paramedic at the same time. So it would be interesting to see if that becomes the future norm in the UK, because certainly there's a lot to be learnt between those two professions, I think.
The other side of that coin is I don't think Tom always recognises how big an advantage he has in austere and pre-hospital medicine, having been a paramedic before he trained to be a doctor. I've been we've had a couple of interesting call-outs recently, and went to RTC together, and Tom, just having been to so many RTC's road traffic accidents as a paramedic, has a completely different perspective on the scene management and all that kind of multidisciplinary police, fire, ambulance, and in some cases mountain rescue attendants at a scene like that, compared to me having come up through medicine, got quite far in hospital medicine before going into pre-hospital setting. For me, the scene management side takes up a lot more of my mental bandwidth. The patient management is absolutely fine, but I have to think a lot more about the scene and everything else that's going on. And so there's stuff that I almost just don't see, or I have to work really hard to notice, whereas it's very obvious to Tom because that's the environment he grew up in, which I guess has parallels to the WPC, in the sense that depending what your background is, you're going to have these blind spots and you're going to have areas where the exam feels really easy because they're the bits that you know really well and use all the time.
So the two of ye have tried to fix this problem. You've created an online review course, and you also have a new revision guide. You have a textbook for this. But let's start with the online review course. Tell us about that.
Yeah, it was fun to make. I genuinely really enjoyed putting together the both of those, actually, because it's an area of medicine that I find very enjoyable and interesting, but also because the blueprint's so broad, it's an interesting challenge to try and teach some of the very specific knowledge that it contains. For example, there are some areas where for this exam, you just have to know specific numbers and cutoff. So hypothermic cardiac arrest, they want you to be familiar with the algorithm that the Wilderness Medical Society guidelines propagate about different body temperature cutoffs and how to do your resus differently. But then there's the other end where trying to teach decision making and working out which patients to evacuate and how to evacuate them. So that was really quite a fun challenge to work out how to teach those different ends of the spectrum. And we ended up dividing the blueprint up into different categories, essentially, and trying to record lectures that cover the specific knowledge that you need, but also that build up to give you the decision-making skills as well. And hopefully that's something we've achieved.
And leading on from that, I think another challenge we had was the WPC exam is specifically for established and experienced advanced life support providers. So the questions may cover core concepts of critical care or managing a trauma patient. And we had to approach that for the revision course and think, a candidate for this exam should already know the core principles, and they should know the core approach to management and the fundamentals of managing those patients. But we need to be sure that they've also covered the wilderness concepts related to that management. So that was certainly a challenge of, we don't want to teach you to suck eggs. We don't want to spend an hour talking you through ACLS or ALS. But we certainly need to touch on, like Ella said, how those protocols vary in a wilderness setting. So whether that's the drowning casualty or the hypothermic cardiac arrest casualty or the lightning strike casualty. So it was working out how to touch all of those it was working out how to tick all of those boxes and not wasting time on concepts that these fairly senior nurses, paramedics, PAs, or doctors will already have under their belt. So that was our challenge of trying to distill down the knowledge that we think you needed for the exam and try to help other people sitting it, because we sourced this huge pile of textbooks and read through them and compared and contrasted between them to try to get that core fundamental knowledge. So it was the challenge of trying to distill that down and then work out what we should present in a prep course. So it was quite challenging, but I think we did a good job in the end.
And I think one of the problems that IBSC had writing the exam is one of the limitations of the format of a essentially multiple choice question exam, which is that you have to choose one answer as correct. And obviously in international practice, in different austere settings, it's never as simple as that. And so sometimes when you're sitting in the exam, you could think, well, I mean, several of these are appropriate, but clearly one of them is the correct answer. And so for us, sitting the exam first was essential so we could get an idea of how they frame the questions, but then going to the blueprint, using lots of different resources and finding what we think is going to be able to let people choose that correct answer out of the multiple reasonable answers that they're going to see in the exam.
So the online review course is available for people?
Yes, it is live through Quorum, and I think it's 16 hours it came out to, something like that. Series of lectures, and kind of lectures each accompanied by just a few short questions to kind of test your knowledge and make sure that the key points have come through, covering the whole blueprint. And that review course should be enough for someone who is already an ALS provider and has some experience in their own field of practice. That course should be enough to get them to the level of the WPC exam.
And additionally, you have the field guide, the workbook that comes with it. So the revision guide. So tell us about the WPC revision guide.
So as I said, we ended up doing quite a lot of reading and amassing this big pile of textbooks. And I guess we thought this is fine if you have the time and inclination and ability to, accumulate a library-sized stack of textbooks. But we recognize that not everyone wants to do that necessarily. And a lot of people will be hugely experienced in this area. And what they really want is they want an exam prep guide. So they probably don't want a huge weighty textbook covering all the nuanced aspect of altitude medicine. What they want is here are the key points, here is the key learning in this topic area that we think will prepare you for the WPC exam. So we had a look at the curriculum. We very strongly based all of this revision guide on that curriculum. And then we distilled down what we thought was the core and fundamental and internationally agreed best practices for all of those elements. Within that, we noticed that there were certainly some areas that, at least for our practice, we were really unfamiliar with, and we think more people will be. So hazards around volcanoes is a core learning point and a core examinable feature on the WPC. And Scotland isn't known for its active volcanoes. So that required a bit of, a bit more of a deep dive, and then trying to distill that into what could they actually ask questions about on volcano hazards. And it turns out there are a lot of volcano hazards when you start reading about them, beyond obviously the burning molten rock. Turns out there's other hazards. So things like that. And then cave rescue, certainly in the UK, again, we're blessed with cave rescue teams who are experts in that area. We might deploy to support them, but I probably wouldn't be traipsing into a cave because I'd probably fall down a hole or something. So trying to distill that into what are the core and internationally agreed fundamentals of this huge specialist area of practice was really a challenge. So we tried to distill that all down, trying to make sure we covered it all. I think the one sacrifice we did make was, again, like I said before, the core concepts around trauma care, critical care, acute medicine. We've covered all of that. That's in the revision guide, but we've tried to really focus it on the wilderness aspects. So you'll still see parts in there about trauma care, critical care. There's a bit in there about ventilation strategies, but we've tried to always skew it onto this is the wilderness concept that you need to consider when doing this trauma care that we assume you're very good at and very competent at. Here are the extra considerations when you're in that austere environment. So that was the approach we took for creating that revision guide.
Yeah, and I think it is funny because really every single chapter of the revision guide could be a whole textbook in its own right. There are massive textbooks on altitude medicine, on even smaller than that, management of acute coronary syndrome, or how you diagnose different diving medicine pathologies. Each of those little bits could be a whole textbook, but we try to be quite disciplined and really, really distill it down into what do you actually need if you're in the wilderness, what do you need to know, because being a professor of cardiology isn't necessary to do the best management that you can in a wilderness setting for those conditions, because there's only so many things you can actually do when you're in a wilderness setting. And what you need to be able to do is recognize the problem, evaluate how serious it is, and work out which patients you need to prioritize for evacuation and give the treatments that you have available in an austere setting. So that was a challenge to get it cut down, but I think also makes it a more rewarding book because you're not mired down in some of the detail that you don't need. And it was really fun to write. I mean, there was some less fun bits of editing, and revision processes are always hard work. But because the topics are genuinely really interesting to us, which I guess is why we've ended up practicing in remote and rural medicine, I can genuinely flick through the book and enjoy reading it and find loads of bits that I still find interesting, despite the fact that I've spent hours reading about them and trying to write about them. So hopefully it's a really useful resource, but one not only useful for the exam, but actually useful for wilderness practice would be my hope. The Wilderness Paramedic Workshop is aimed at anyone who's interested in sitting the exam, giving them a shorter version of the online review course. So distilled down even more into the absolute essentials for the course, giving a taster of what the whole exam covers, but focusing on the areas that I think, or that we think that are going to be the most common lacunae in people, or blind spots in people's current practice. So trying to focus on the highest value areas of the curriculum for people to upskill in, to prepare for either wilderness practice or to prepare for the exam.
And I guess it's worth saying that both in the book, the revision book, and in that workshop, we've written a number of questions that we think really closely mimic the actual certification questions. Obviously, it would have been lovely if IBSC released their whole question bank to us, but unfortunately, they're not able to do that. So we had to come away from the exam and think, okay, how did IBSC structure their questions, and try to get into their mindset of how are they actually testing concepts using this multiple choice question format. So hopefully we've done that quite well. And certainly in the textbook, in the revision, the prep guide, we have a full practice exam in there. So if you're not someone who loves sitting exams, you could work through that whole book, and then you could sit a full mock test. And we'll present some of those at our workshop at SOMA as well, again, for people just to get in the mindset of the multiple choice question, because I think, like Ella said earlier, a number of these questions really are single best answer. So perhaps two of the answers are okay, but you need to distill down which of those answers is the best answer in that wilderness scenario. So we recognize we're from the fortunate background of medicine really embraces exams. So we've both had to sit loads of exams. So hopefully our exam technique is fairly good, but we recognize that not everyone embraces exams in the way we've been forced to. So we hope that giving an opportunity to look at some of those questions, and then in the workshop talk about why we think something is the correct answer and how we've reached that decision, we're really hoping that will empower people to relax a bit and think, oh, I understand what I'm going to be presented with during this examination, and I understand how to dissect out what is the best answer out of perhaps a number of answers that would be acceptable. So hopefully that will be really helpful for attendees.
And we're hoping some of the people who've booked onto the workshop are planning to book onto the exam the same week. So IBSC are holding a special sitting for the WPC exam that people will be able to do while they're at SOMA. So they can come to our workshop, and then a couple of days later they can sit the exam and hopefully reap the rewards of us having given them that kind of brush up. The other benefit for people coming to the workshop specifically is they're going to be given free access to the online revision course. So if they're planning on sitting the exam at a later date or want to get into a little bit more detail in any of the topics we cover, then they'll have access to that on the online revision course as well. So the workshop's going to be covering some of those core details, but like Tom says, giving a little bit more of that live interaction so we can actually talk about how do you make that decision making, how do you choose between the different questions, what are the questions trying to get at, and it'll be fun to be able to do something that's a little bit more interactive after preparing the revision guide for online teaching, where really at the end of the day when you're creating that material you're just talking at a camera, and it's a lot more fun to talk with people who've already got knowledge and experience and make it a two-way process.
This is your third SOMA conference. What presentations are the two of you looking forward to attending?
So I'm going to jump in because I feel really lucky because I've managed to book onto, I can't remember the exact name, and I'm really sorry, I can't remember who's presenting either of these workshops, but I have booked on the auricular acupuncture, so like the battlefield acupuncture course or workshop, because I've been reading about that for a while. It's quite tricky for us to track down those courses. There are some in the UK, but we're geographically right in the north of Scotland. So it's just quite tricky to get time off to go to any of these courses. So I was really pleased to see that offered at SOMA because we're at SOMA. So I pounced on that opportunity for the acupuncture for pain relief, because that sounds great, right? Like there's no drug side effects. It's lightweight. It's portable. I understand it's fairly easy to undertake, but I will reserve judgment until I've been shown and then tested on how to do it. So I'm really excited I managed to get a place on that. And then the other one was the expectant casualty care workshop, because I think there's definitely a deficit where when we talk about mass casualty incidents or major incidents, we're very good at teaching the triage flowchart. We're very good at saying this group of patients, you give them a blue tag or a whatever color expectant tag. Expectant being we do not expect this patient to survive no matter what resources we throw at them, or perhaps more nuanced of we do not have the resources available to give to this patient because we have an overwhelming number of other patients. And I think we're good at teaching that. And then we say, so you label that person expectant, you expect them to die, and then we put a full stop after that and no more is really taught. Whereas there's a space there for end-of-life care and palliative care, but being delivered in a challenging, austere, pre-hospital setting. And that's certainly a void there where we haven't really given people that education, and different agencies and individuals have been faced with those situations and they've had to negotiate how do you provide that level of palliative care with essentially no guidance. And my understanding is the Department of Defense is now looking at that, and I'm sure they have some really, really excellent insights. So I'm looking forward to hearing what they have to say and where they're coming from, and then comparing it to my background and my previous education in palliative care in a rural setting, but clearly in a much more controlled setting than the mass casualty incident where it's a challenge. So I'm really looking forward to hearing where that workshop goes and the approaches they're talking about for expectant casualty care. So they're the two I've booked onto. And I'm really looking forward to them. I feel really lucky that they were available and I managed to bagsy a space on both of those.
Yeah, and my answer maybe sounds like a cop-out, but genuinely the bit I'm most looking forward to is in the kind of presenters hall, getting to meet all the other people that come along to SOMA, because I think I have got a huge amount out of attending workshops at SOMA previously, but I've also got so much out of just talking to the other people who are there, and I've had really interesting conversations and kind of got to know people who are working in really interesting places, and just little things like traction splints for mountain rescue. Last year I got to speak to Sam Slishman, who designed the Slishman traction device, which is an alternative to the Kendrick traction device that is more commonly used in the UK, and he was able to supply me with one that we've been trying out in training with my team, and it has so many advantages over the KTD. So it was really cool to get to actually speak to the inventor, and he was very gracious when I was asking some maybe quite challenging questions, just questioning the efficacy of it and talking about different features that it had. And so that was a really cool opportunity, and I'm really looking forward to just being there and getting to know some more people. I'll also, obviously there's some incredible talks that happen every year, and it always feels quite a privilege just hearing from quite eminent people, and also getting insight into some really difficult scenarios people have been through, because the presentations at SOMA often address events that were really difficult, and I always find it very impressive when people are willing to come and talk about events that maybe didn't go brilliantly well and reflect on challenges that they faced or difficulties their team have overcome. So looking forward to those as well, but mostly to the people side, getting to know other people there and hearing about what they do and how they do it.
I'm going to jump onto the Slishman traction splint. This isn't going to become an advert for that particular traction splint. Other traction splints are available, but I was working with our mountain rescue team, and we were putting on the Slishman and the other traction splint we were using. And anyone who's used those traction splints that stick out beyond the bottom of the patient's foot, when you come to packaging someone in a litter or a stretcher, especially in mountain rescue where you then have to either winch them out or carry them out, suddenly being able to put the Slishman on and it fits in the CAS bag, and you can keep your patient much warmer, and you then don't end up kicking the end of the traction splint, which I admit that I have done on a number of occasions, not to be horrible to patients, but just because I'm clearly more clumsy than I think I am. The Slishman was easy to put on, but then allowed you to carry on providing really good care to your patient without creating a stumbling block or a hurdle. So, I guess it is a bit of an advert. I really enjoyed working with our mountain rescue team on that new piece of kit that is just making its way to the UK. It might be really familiar to more North American colleagues, but for us, that was quite a new bit of kit, and we really enjoyed playing with that. So things like that, it would be great to go back to SOMA and walk around that exhibitors hall and get an idea of what else is being developed and invented, and what else perhaps we can bring back to the UK and start talking to people over here about. So that's always it's always very exciting.
And I find it funny because at a lot of conferences, the exhibitors hall doesn't overly interest me, because often the sponsors are just exhibiting stuff that you have to be so high up in the food chain that you would basically need to be purchasing for a whole hospital, or even bigger, like purchasing for a network. And so I haven't always felt like exhibitors halls are really aimed at me. But SOMA is one of the few where there's people exhibiting products that are directly relevant to me as someone who's actually doing the practice on the ground. So it's a lot more intriguing to wander around. And genuinely, the only other conference where I've had that experience is at the Medicine in the Mediterranean conference that Corrick holds, most recently, where we were looking at new vacuum splints that were being exhibited and that were fantastic. So it's just nice seeing stuff. And I suppose, again, it comes back to what you started us off talking about, Aebhric, that although it might have been a soft conference, actually so much of what's at SOMA is relevant to what we do in rural medicine and in wilderness medicine. and that's reflected in the exhibitors hall and makes it really fun to go around because there's all these new gadgets and interesting devices, and then there's also improvements on things that we've been using for years. So it's really enjoyable to look around and find out what's out there.
Yeah, SOMA is definitely one of the high points, and this is my 12th, I think, and it's just fantastic to see all the toys that are coming out, like Rescue Essentials with Schleichmann Splint, and now there's Sam Medical as well. That they're good people. You don't get that icky feeling of they're trying to get you to sell crap, and so it's always a pleasure to walk around the exhibitors hall, and of course we'll have our table there. All three of us will be taking our turns at the Quorum exhibitors table. Any listener coming to the SOMA conference, you've got to come by and meet Tom and meet Ella and see what we're doing at the college. And Tom, Ella, as always, my final question for you is this. What advice do you have for the new medic, the new nurse, the new doc who is just starting out in their career in austere medicine?
I think I might have said something similar to this previously to you, Aebhric, but my advice is to take opportunities that excite you and that interest you, because even if if you're not sure the long-term outlook of something that interests you and you don't stay in that role forever, you will learn things, and then 10 years later some other opportunity that excites you comes up, and suddenly you realize, oh hey, I did that other thing for 2 years, and that gives me exactly the skills these guys are looking for. And the reason that you get access to those exciting opportunities later is because you've built skills in things that you enjoy and that inspire you, and that has worked out really well for me, and I think it's a really good rule to live by.
I'm going to go in a different direction, and I'm going to echo something Ella said earlier about SOMA being a forum where people discuss things that didn't go well, either because the situation was challenging or equipment failed or they had a mind blank and didn't live up to the level of provision they wanted to provide. So I'm going to jump on that, and I'm going to say my top tip is to embrace what we, certainly in the UK, we talk about it as crew room banter or crew room discussions. So if you've had a case or a job or a patient care episode that you think didn't go very well, or that was just really hard work, that was just really challenging, to embrace discussing that and being honest with your colleagues. And then they will have a story about their case that didn't go very well or how they overcame a similar challenge. Because I think you could go through life only learning from your own mistakes, and that's certainly, you should learn from your own mistakes. But if we could go through life and we can learn from 20, 50, 100 people's mistakes, then we've really accelerated our learning, and hopefully we've really developed ourselves much quicker as a clinician, and we can provide better care. So my top tip is, don't be afraid to discuss things you think went badly or didn't provide optimum care to your patient, and learn from other people's solutions presented to you, and also try to tease out other people's stories of when they think things didn't go ideally, and then learn from their mistakes on their challenges as well. Because I think, especially in austere and wilderness medicine, it is such a challenging environment, and you're presented with such weird and unique challenges that the challenge someone else had, maybe no one else is going to have for a decade. So if you can learn from it now, you can pass that knowledge on to someone else, and hopefully we will improve the care of either a patient you see, or perhaps in 10 years' time, you can tell that same story to someone else, and then you can improve the care that a patient receives in a decade's time. So I think embrace talking about the challenges. That's my top tip.
Dr. Tom Mallinson, Dr. Ella Corrick, it is fantastic to have the two of you carrying the torch of Quorum and holding the leadership roles that you have within the college. And I am so happy that you have embraced SOMA and embraced your role and your input into SOMA. And because you guys are going, continually attending and now presenting at SOMA, you are making the soft community a better space.
Well, I hope so. I think we've certainly had really interesting discussions. We've certainly learnt lots from it. And yeah, hopefully now we're moving into presenting. Hopefully we can feed some of that back.
Yeah, I'm very grateful to be made so welcome there. I'm really looking forward to it.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at coram.edu.mt.